quite a lot for that. So I'm working as an assistant professor in hematopathology. So let's start the topic. So to begin with, we should be knowful of the certain things about osteomyelitis. That is definition. How are we going to classify? What are the organisms commonly involved? How does it affect the joint and the bone? So what is the route of the entry of the organism to cause osteomyelitis? Can you see the slide? You can't? Wait. Sorry. You're not able to view it. Yeah, I'm seeing. Hold on. Now, can you view now? Can you see the slide? Could you please respond back? Okay, great. Great. So let's continue with the topic. So we should be knowful of the fact of what osteomyelitis is. How will we going to classify acute and chronic? What are the organisms that leads to osteomyelitis? And the common ones. And how does the organism gains entry to the bones and the joints to cause this disease? How does the disease manifest? How will you going to diagnose? And what are the treatment options? Okay. So, as you all know, osteomyelitis is the inflammation of the bone and as well as bone marrow. And it's almost always secondary to infections. Okay. So infections are the cause, and those infections could be anyone. It could be viral, could be bacterial, could be parasitic, could be fungus. And it could be, it could be one of the manifestation. It could be a part of a systemic infection going on in the body already, or it can be it can occur in isolation. Like osteomyelitis can occur in isolation and cannot be a part of the systemic infection going on. So it can be either way. So it could be the causative organism could be anyone from bacteria to viruses to parasites to fungi. But bacteria are the most important one, and in our population, mycobacterium, after the bacteria, mycobacterium comes second to that. So bacteria is the most common cause of osteomyelitis. Okay, remember that. So what are the roots? It could be acute, it could be chronic, it could be subacute. Okay, we're going to talk about it later on. So acute hematogenous osteomyelitis is caused by the infections caused by the blood-borne organisms, and usually occur in children. And it's as a part of sepsis, and it's the earliest presentation is the acute soft tissue swelling, leading to bone demineralization, and then forming a sequestrum, which is a dead bone with surrounding granulation tissue. And then there's a new bone formation because of the because of the inflammatory cells are secreting the mediators, which stimulates the formation of osteoblasts. Those osteoblasts starts making new bone, which is kind of fragile, and you call this new bone as involucrum. So initially there will be a soft tissue swelling as a part of an inflammation, where all the neutrophils are gathering and edema is happening and vascular leakage is happening. Okay. Then after that, there will be bone demineralization, and then which subsequently leads to dead bone because of the thrombosis and the ischemic infarcts in the bone. So there is a dead bone, and the dead bone is surrounded with a granulation and histiocytic tissue. The sequestrum is then get it then gets confined by the involucrum, which is a new bone formation. So these bacteremia, minded, they can be from very can occur from from a very petty kind of a mucosal injury. How does the bacteria enter? It occurs it can be due to any prolonged straining by defecation, especially in children, or if they are chewing very rigorously. So the bacteria can there must be this causes mucosal damage, and then the bacteria gains entry and it penetrates the bone. For adults, if we talk about, the commonest cause is for this for not the hematogenous, but the commonest cause is are the compound fractures, or if it could be diabetic infections of the feet. So for children it's different, the causes are different. From for adults, the causes are different. So as I talked about, acute osteomyelitis could be due to after open fractures or after open reduction with internal fixation, usually in adults, and that leads to hematogenous osteomyelitis. That is if the organism first gains entry to the blood and then it penetrates into the bone. So the treatment is for such kind of for acute treatment is radical irrigation. Okay, and with the debridement of the sequestrum, removal of the orthopedic hardware, if there is any fixation device, if there is any uh, internal fixation device, any prosthesis joint is been installed, is being there in the joint, you have to remove that. The organism which is commonly involved, most commonly 90 to 18 to 90% of the time, the organism is Staphylococcus aureus. There are then other organisms also like E. coli, Pseudomonas, and Klebsiella, but they are mostly in patients who are already having, GI, genitourinary infection, or those who are intravenous drug abusers. But the commonest one is Staph aureus, while Pseudomonas and Klebsiella are for those is the causative organism in mostly in the intravenous drug abusers, and the one with the genitourinary UTI, genitourinary tract infections. So these organisms basically they first bind to the bony matrix, okay, like that is collagen, and then it gains entry into the bone. Uh, and mind it, for the sicklers, the commonest organism is why do we sicklers have osteomyelitis? Because in sickle cell anemia there is the cells, when the cells become sickle cell due to hypoxia, those sickle cells are very sticky cells. Those they get stick to the vascular endothelium. They causes ischemia and necrosis. So ischemia and necrosis in itself is one of the the provoking factor for an organism to grow. Okay, because it leads to lactic acidosis and everything. So when there is ischemia owing to the sickle cell crisis, the organisms, the most of the labile organisms, they become active. So that can also, sicklers are also very prone to osteomyelitis, and in the thing in the sicklers, the organism is Salmonella, which causes osteomyelitis. So you should be, it's very important from the exam point of view to be knownful of the name of the organisms that leads to osteomyelitis in a different settings. For example, if you talk about neonates, it's group B streptococci and Haemophilus influenza. So it's different for different categories. The causes are different for different category, for the different ages, and the organisms are different for different for the different setting of the infection. So when you talk about chronic myelitis, it may arise as a result of ongoing osteomyelitis, and when you inappropriately treat it, or when there is a delay in the diagnosis, and it can happen in immunosuppressed patients, in diabetics, and in IV drug abusers. So treatment is almost same, but the damage is more devastating. So you need a bone grafting in chronic osteomyelitis, and obviously, an amputation could be we have one has to contemplate amputation. So in chronic osteomyelitis, the damage is more severe. Then there's subacute osteomyelitis, which is usually discovered radiologically in a patient with a painful limb and no systemic signs or symptoms. So if you can see, there is a circumscribed. This is this Brody's abscess. And what is Brody's abscess? It's a small intraosseous abscess that frequently involves the cortex, and it's it's cordoned off by the reactive bone. So this is the reactive bone, and this is the Brody's abscess, and it's usually intraosseous and present in the tibia. So you can see the Brody's abscess over here, and you can see there is this periosteal edema and periosteal reaction at the diaphysis at the lateral. This is the lateral view. So you can see this edematous changes in the periosteum, which have. So we already talked about it, that the how does the infection and gains entry either by the hematogenous through the bloodstream. Okay, then it could be due to contagious focus, like you do an internal fixation, or you just due to any compound fracture or extension from the adjacent tissue infection. Okay, and then there could be direct infection into the bone, as happens in the sicklers. So we already talked about the organisms. The organisms, 80 to 90% of the time, is the Staphylococcus aureus, E. coli, Pseudomonas, and we talked about, and Klebsiella, not mentioned over here because they are most common in IV drug abusers. And Haemophilus influenza and group B streptococci are more common in neonates, and Salmonella are more common in sicklers. So what are the sites of the bone which are most commonly involved in osteomyelitis? It can be any bone, but most of the time it's the long bone. So, sorry, the ends of the ends of the long bones are commonly affected, extremes of the long bones, okay? And metaphyses of the long bones metaphyses of the long bones adjacent to the actively growing endochondral plate, and at the metaphysis, the bone marrow space becomes dilated, favoring sluggish circulation, ideal for multiplication of bacteria. And another, it can also occur. It can also affect the vertebral column, as happens in Pott's disease. So the commonest point to that in which the bone is in which the birth in the osteomyelitis, the commonest site is the metaphysis of the long bones. And when there is periosteal when there is swelling of the periosteum and inflammatory reaction, this further retards the blood flow, and this which becomes a cherry on the cake. And with the further when there is further sluggishness of when the blood flow becomes further sluggish, the condition becomes further aggravated, and the bacteria becomes starts multiplying, and it increases exponentially. So as you can see, the 36% of the times, it affects the long bones. It can affect any of the bone of the body, but mostly it affects the. Just hang on for a while. We're going to take questions at the end, okay? So please don't post the questions right now. Okay, so 36%. So most of the time, the long bones, that is femur, is affected, which is then followed by the tibia. Okay, but it can involve virtually any of the bone of the body, but these are two commonest bones that are affected in osteomyelitis. So sometimes dental abscess, the organism can gain access to the bones and the joints from the dental abscess. or from the penetrating wounds, or from the contamination of the compound fracture, or following surgery, or it could be due to placement of the implant, prosthesis, or any surgical device from where any valve presence of the any mitral, any synthetic or bioprosthetic valve which is present in the implanted in the heart. Or it could be due to it can gain entry from acute virulent frontal sinusitis, or can gain entry from, very commonly in elderlies, it can gain entry from the pressure sores or the bed sores, which leads to the osteomyelitis of sacrum. So it can separate so these are the endocarditis, upper respiratory tract infection, genitourinary surgeries, and drug addicts, and any separative infection of the skin like abscess, boil, or any separate any any skin infection can lead to hematogenous spread, and it leads to osteomyelitis. So how does osteomyelitis actually occurs? Firstly, the bacteria gains entry to the site, to the joint, to the bone, where it proliferates. And as a response, the neutrophil migrates to that focus, and neutrophilic inflammatory reaction occurs, and the neutrophils and the monocytes, they start secreting mediators. Those mediators leads to the necrosis of the bone cells, and as well as the necrosis of the marrow. And then it starts traveling from inside to the outside, from the via the Haversial system, and it enters into the periosteum, and where it causes all this the same inflammatory reaction, like the the migration of all the inflammatory cells. And these inflammatory cells, they start secreting platelet derived growth factors. They start secreting fibroblast growth factors. So these they start making they start making the marrow fibrosed. They start making the bone necrosed. So this is basically the necrosis and fibrosis is basically the result of the mediators being secreted by all the inflammatory cells which have been recruited in response to that infective organism. So, and mind it, what happens in children, there is a subperiosteal abscess formation. Such thing doesn't happen in adults, because in children the periosteum is not is somewhat loosely adherent to the cortex. So there is a gap between the cortex and the periosteum. So when those cells and are migrating, when the cells are migrating to the periosteum, they start to inhabit that in that in that dead space between the periosteum and the cortex, and this kind of causes that this kind of causes uh, subperiosteal abscess. You call that subperiosteal abscess in the children specifically. So the end result is that the bone starts becoming the marrow starts getting necrosed, and the bone starts getting necrosed. And what you call this dead bone, that you call this dead bone as a sequestrum. Okay. So, and the periosteum starts to burst, and this periosteum, first the marrow is affected, then the bone is affected, then by the Haversial system, the periosteum is affected. And then there comes it starts taking its now these inflammatory cells and this all mediators, they start gaining they start making their way towards the skin in the form of a sinus. They make a sinus tract. So sometimes they make a sinus tract, and one can see that there is a pus coming out of the skin. So this is a devastating condition. I mean, it shows that it has affected all its all the channels. It has affected the bone, the marrow, the periosteum, and now it has come out of the skin. So so these chronic inflammatory cells, always remember, they secrete these cytokines, and these cytokines also, what do they do? They make the bone necrose, they make the bone fibrose, and they also secrete certain mediators that causes, initially that they causes the formation of osteoclasts. So osteoclasts are bone resorption cells. That's where the necrosis occurs, and they are also secreting fibroblast growth factors. So fibrosis is being happening when a marrow becomes fibrous, it becomes non-functional. So the bone becomes non-functional because of the osteoclast. Bone marrow becomes non-functional because of the ingrowth of the fibrous tissue. And then what happens? The osteoblasts are also being produced at the same pace, because the mediators, there are certain mediators which are also forming, which are also recruiting osteoblasts. So osteoblasts are the bone forming cells. So simultaneously the new bone is also starts forming, which cordons off, which shells off the devitalized, and the dead and the necrosed bone. And what do you call that, newly deposited, and that, the novice, and the new one, and the fragile kind of a bone, you call that involucrum. So involucrum basically cordons off the sequestrum, what you can say in an easier way. And so now let's go to the slide. So the microbe gains entry into the site of into the bone or the joint, leading to inflammation. And when we talk about inflammation, it means all the neutrophils and the lymphocytes and the eosinophils and the monocytes have been mostly the neutrophils and the monocytes have been recruited over there, and secretors and have started secreting their mediators. So obviously, we have also read that when these mediators are being, when these cells, when there's edema, because owing to the inflammation, the vessels which are present which are juxtaposed, they starts getting obstructed because of the pressure of that inflammatory thing going on in the background. So they become occlude. They starts occluding. The vessel starts getting compressed, so the phenomenon of thrombosis occurs. That thrombosis adds up and can lead to necrosis. So other than that, these microbe gains entry to the medullary cavity, periosteum, and adjacent tissues, and leads to bone abscess formation. This inflammation leads to increased vascularity, edema, and the thrombosis leads to ischemia with a bony necrosis, and bone abscess formation leads to Brody's, what you call that, a Brody's abscess in a scientific term, that leads to sequestrum. And sequestrum then, and outside the sequestrum is followed by involucrum. The new bone gets deposited, and that leads to chronic osteomyelitis. So just have a look at this slide. These are all the chains of events that are occurring simultaneously. So just have a look at this and try to remember all these things. As you can see, this is the Brody's abscess, microabscess, which is being formed just adjacent to the metaphysis. Okay, and as soon as it as soon as, because what is this pus? This pus is basically a collection of necrotic debris and all the inflammatory cells. So as soon as when it starts this when this pus becomes large size, it starts recruiting all it starts secreting more and more mediators, which due to which osteoclast and osteoblast starts forming. These osteoclasts are the, you can see these osteoclasts are the bone resorbing cells. They're resorbing they're causing bone resorption in the and causing making sequestrum. And then they can see that there is this subperiosteal woven bone, which usually happens in kids, in children. And this this pus is gaining entry, this pus and this all inflammatory cells is gaining entry into the cartilage plate. Okay. And now this all abscess is started having gaining access to the periosteum and into the epiphyses, and there comes at a point where it starts invaginating, invaginating, and it starts making its way towards the skin in the form of a sinus tract. So you can see that there's also reactive bone formation as happens in chronic myelitis, and you call that involucrum. This involucrum basically cordons off all the dead tissue. So this is involucrum. Okay. And you can see this is fibrosis, marrow fibrosis. Initially, it was see pink. The bone marrow, this is a bony cortex, and inside it's bone marrow. Initially, it was pink, but with the sequence of the events, it started getting fibrosed. You can see these blue lines. It's all getting fibrosed. See, so the bone marrow is becoming non-functional. And minded, bone marrow is the site of the formation of all hematopoietic elements, like all your neutrophils, your red blood cells, and your platelets are being formed over here. So when it starts getting fibrosed, your hematopoiesis is seriously hampered, and it becomes non-functional. So this is the reactive bone, which is cordoning off all the dead tissue. Okay, you call that involucrum. And this is the sequestrum, non-functional kind of a dead bone. So how does it manifest in infants? It's failure to thrive, drowsiness, because if it occurs as a part of systemic infection, there can be minimal constitutional symptoms, and there could be effusion into neighboring joints. There could be pus formation. So, and most of the time there will be history of antecedent trauma. There will be involucrum and sequestration. We already talked about it, and there could be an associated septic arthritis. In adults, in adults, the hematogenous osteomyelitis is less common. I told you it's mostly direct, and it usually gains entry directly. So it spreads infection directly to the joint space. And vertebral osteomyelitis is more common in more than 50 years of age. But if it is whenever there is hematogenous spread of the organism, when the organism gains entry to the joint via the blood, there will always be constitutional symptoms. Okay, there'll be high fever, there'll be chills, there will be malaise, there'll be rapid pulse, there'll be there could be shock. So at first, systemic signs may overshadow the local signs. So systemic signs are so prominent that sometimes the local sign, that is the pain and the limping, can be overshadowed. Constant pulsating pain then intensifies with the movement. Swollen and tender areas of infection then becomes visible, and chronic osteomyelitis presents continuously draining sinuses or recurrent inflammation. Mind it, this is the dangerous thing. When this occurs, it means that it has been progressed. So what do you get? You get CBC done, and probably if it has affected has caused marrow fibrosis. You can see cytopenias. You can see the increased WBC count. Okay, you can see increased platelets, because sometimes you can see low counts when there is myelofibrosis, and sometimes you can see increased WBC count then there is no myelofibrosis. When this inflammation is not severe enough that the fibrosis has occurred, then you can see, in that case, you can see neutrophilia. ESR would be raised, obviously, because of the infection. Blood cultures usually 80 to 90% of the time it will yield a Staph aureus. Okay, always remember that. And biopsy of the affected bone, that will lead all the sequestrum and involucrum. And X-rays can give you an insight about the edema and the periosteal swelling. And then can be bone scans, and MRI would be more conclusive and we will be more confirmatory. So, what are the complications of osteomyelitis? It can lead to septicemia. It can occur as a, always remember, it can occur as a part of a septicemia, or it can lead to septicemia. So, it can be any way. It can be other way around as well. So, septicemia leads to disseminated abscess formation, and it can also lead to infective endocarditis. Okay. It can lead to septic bacterial arthritis. It can lead to pathological fractures. It obviously it can cause alteration in the growth rate in the infants, in the children. It can lead to squamous cell carcinoma, pretty rare, but does happen. Amyloidosis and chronic osteomyelitis. So, what are the vertebral? In adults, epiphyseal infection. Some in adults, the epiphyseal infection spreads to the articular surface or along the. Oh, sorry. That's not the thing. So, in vertebral related complications, can cause neurological manifestation. It may lead to vertebral collapse. It can lead to if you talk about mycobacterium or the Pott's disease, in that case, it can lead to paravertebral abscess. It can lead to spinal epidural abscess. It can lead to cord compression. And cord compression is a medical emergency because it can then lead to anuria and paraplegia, or it can lead to compression fractures. Okay, when it affects the vertebral joint. One third in tuberculosis can cause osteomyelitis, and one third, especially in the developing countries. So it's one of the leading cause of the death. And one to out of all the manifestation of out of all the tuberculosis patients, 1 to 3% manifest as skeletal TB. So the ratio is very low, but still 1 to 3% can out of all the TB patients can end up having skeletal TB. And it spread from the primary complex to any bone, like spreads from the bone focus to any bone or any joint. And it can affect any bone, but the weight bearing bones are more likely to be affected. Spine is the commonest, always remember. And then it is followed by knee and the hip. So the weight bearing joints are affected. In tuberculosis, most commonly it affects the spine. So back pain of variable duration, fever and weight loss, and again there's just hang on. Then there is a local tenderness, then there is a spasm, then there is gibbous, and we know that gibbous is a form of a structural kyphosis found in the upper lumbar and the lower thoracic vertebra, and where one of the adjacent vertebrae becomes wedge shaped, and it usually occurs in the young children as a result of spinal TB, and it may leads to collapse of the vertebral bodies. So there will be gibbous formation, there will be cold abscess, and then obviously that can lead to paraplegia and paraparesis. X-ray would show erosion of the anterior edges of the superior and inferior borders of the vertebral bodies with narrowing of the disc space, and that disc space is basically occupied by the inflammatory cells. And ultrasound would show paravertebral abscess, and biopsy would be confirmatory, where you can see the granulomas. So TB of hip joint, there's pain, limping, and irritable hip, gradual loss of the range of the movement, flexion deformity, wasting of thigh muscles, and early changes are the rarefaction of the bone and widening of the joint space. Later on, there is destruction of the joint, and synovial biopsy would be more confirmatory. So, what are the complications of the Pott's disease? There will be cold abscess formation. That is, there will be no acute inflammation, only necrotic debris and caseation. And caseation, as we all know, that it's the collection of the histiocytes and cheese and all the cheesy material which is coming out of the histiocyte leads to caseation. Then there is rupture into the soft tissue along these anterior spinal ligaments, which may cause paraspinal abscess. Then it can spread along the psoas muscle, and it can cause psoas abscess. And it may causes some, it may, may cause cord compression. Spine may, put the pressure on the spinal cord, and once the spinal cord gets compressed because of all the, of all the abscesses happening in the bone, once the spinal cord gets compressed, it leads to paraplegia, it leads to anuria, it leads to, uh, it leads to fecal incontinence, urinary incontinence, it leads to paraplegia. It's a very devastating condition, and it can causes angular spine. Kyphosis is the most common thing. Chronic, if they, what about, now we're coming to the chronic osteomyelitis. So if the acute process fails to abate completely, it leads to chronic osteomyelitis. And chronic osteomyelitis develops in 4 to 6 months. Uh, and when there is whenever there is a delay in the diagnosis, or whenever you give an inadequate antibiotic coverage, or whenever there is not whenever there is improper surgical, not a incomplete surgical debridement of the necrotic tissue, this leads to chronic osteomyelitis. Okay, so incomplete management, delay in the diagnosis is the most common cause of the chronic osteomyelitis. So it develops in 4 to 6 months. There is regular exacerbation occurs. Fistulas are the adjacent the connections between the two tissues. Fistula remains, and the discharge of the pus continues. The outcome depends on the severity. A change to the chronic stage may be encountered in 10 to 30% of the cases. And you shouldn't be wary of the fact that the chronic osteomyelitis may lead to pathological fractures and secondary amyloidosis, and sometimes it can, the draining sinus tract can lead to, there can be squamous cell carcinoma in that draining sinus tract, and very rarely it may cause osteosarcoma, as well as sometimes it may lead to endocarditis and sepsis as well. So these are all the complications of the chronic osteomyelitis, and you should be wary of that because it may be asked in your exams. So these are all the necrotic tissue, okay, all the inflammatory cells. These are all the inflammatory cells, neutrophils, and this is binded. This is all necrosis. This pink thing is all necrosis. This is necrosis. This is necrotic tissue. This pink thing is all necrotic tissue, and these are all inflammatory cells, lymphocytes, neutrophils. So this is a draining sinus. Okay. This is one of the complications of the chronic osteomyelitis. This is all that necrosed tissue. So this brings us to the end of the osteomyelitis. Yes, when we talk about mycobacterial osteomyelitis, it is tuberculous osteomyelitis most of the time. It is actually Mycobacterium tuberculosis. See, Brody's abscess. If you talk about Brody's abscess, then abscess is basically a collection of inflammatory cells, all the inflammatory cells and the pus. Whereas sequestrum is a dead tissue. No inflammatory cell, nothing, it's necrosed. Sequestrum is a different thing. It's a necrotic tissue, necrotic bony tissue, dead bone, okay? Whereas abscess, when you talk about abscess, if you see the definition of abscess, all the collection of inflammatory cells, and it's localized, okay? It's cordoned off, it's walled off. It's with a thick wall, it has a thick wall, and all the pus and the inflammatory cells are there in the abscess. Sometimes the organism was also there in the abscess. So both are different. So I think we don't have any more questions. So let's end the session over here. Okay. Just go and read osteomyelitis from your textbooks. Okay. Thanks a lot. Thank you. Thank you for your patience and for your time.